Hi my dear students, hope everyone is okay. Today we will see about something about vital statistics. As you all know, vital means important. We have heard about vital signs, so vital is important. So statistics is the maths. So vital statistics we will see. Vital statistics are the statistics on live birth, death, fetal death, marriages and divorces which occur in a particular country. The most common way of collecting information on these events is through civil registration, an administrative system used by the governments to record vital events which occur in their populations. You might have seen in a hospital soon after the birth of a baby, they will do the birth registration, and death of a patient, they will fill up a form and give for the death registration. So, there is another term SMI. It is nothing but Safe Motherhood Initiative. It is a global effort to operate through the partnership efforts involving in the government, non-governmental agencies, other groups and individuals. SMI or Safe Motherhood Initiative aims at improving the woman's health through social, community and economic interventions. Economic wealth is not sole determinant in averting the maternal death. Safe motherhood means ensuring that all women receive the care they need to be safe and healthy throughout pregnancy and childbirth. Considering the high maternal mortality rate in the developing countries, WHO in 1987 developed the idea of Safe Motherhood Initiative at a conference in Nairobi, Kenya. The global effort to reduce the maternal death by half by 2000 AD, now extended up to 2010, it is again extended up to 2020. Maternal death attributed to the direct causes just APH, antepartum hemorrhage, postpartum hemorrhage, pregnancy-induced hypertension, eclampsia, obstetrical labor, and rupture of the uterus. Indirect causes include age at marriage, unsafe abortions, inadequate perinatal care, lack of trained health professionals. Pregnancy and childbirth global situation. 50 million There will be 50 million induced abortions, 20 million unsafe abortions, 20 million women suffer from maternal morbidity, 60,000 die from the complications, 3 million newborns die within the first week of life, 3 million babies are born dead. This is the global scenario. Then, pregnancy is a physiological process in a woman's reproductive life. Yet, this is associated with certain risks which may cost a woman or newborn's life. Of 100 to 2000 million deliveries occurring worldwide, 50 lakh women died during pregnancy, childbirth or soon after. Many more suffer chronic ill health in form of anemia, cancer, cervix prolapse and fistula formation resulting from childbirth. 99% of these deaths occur in developing countries. This is a human tragedy and social injustice to women because just they are being in a developing countries, they have to suffer all these things. It is the woman's right to receive proper care during the reproduction which is denied to many women in our country. Safe motherhood should begin before conception with an advice on proper nutrition and health. It should continue with planned and unwanted pregnancy and neonatal supervision throughout pregnancy and safe delivery. It is extended to puerperal period with proper lactation, diet and care of newborn and immunization. Every minute, 380 women become pregnant. 190 women face unplanned or unwanted pregnancies. 110 women experience a pregnancy-related complication. 40 women have unsafe abortion. 5 babies are born dead. 5 newborns die. And 1 woman dies. Safe motherhood includes antenatal care, that include the early registration, that minimum 4 antenatal visit, first at 16 weeks, second between 24 to 28 weeks, third 32 weeks, and fourth at visit at 36 weeks should be carried out. Risk approach to identify high-risk cases during the pregnancy, labor, and viparium, and appropriate referral system. Routine immunization with TT and supplement. TT means tetanus toxoid and supplementary iron folic acid daily for at least 100 days after the first trimester. Second, in neonatal care include institutional deliveries by skilled persons, 3 cleans, that means 3 clean hands, clean perineal area, and clean umbilical area must be maintained. Postnatal care includes support to restore the health of the mother and care of the newborn, breastfeeding, early and exclusive breastfeeding, family planning services. Then essential newborn care, clean delivery, resuscitation at birth, prevention of hypothermia, prevention of infection, breastfeeding, early and exclusive breastfeeding, 10 baby-friendly initiative. Then referral of a sick born child. Basic facts underlying the clinical causes of maternal death are: first one, low socioeconomic status of girls and women, that is gender inequality, poor nutrition, lack of skilled attention during the time of delivery, appropriate referral system, emergency obstetric care, sex education, family planning, safe abortion services. You might have heard about RCH or reproductive and child health care. RCH care is an integrated and composite approach to improve the health status of women and children in India. It incorporates the output of government in India and support donor agencies like World Bank, WHO, European Commission, and others. The aims of RCH interventions include safe motherhood, child survival, adolescent health, family planning, and prevention and management of sexually transmitted diseases. Infections. The main objective is to reduce maternal mortality by 3/4 and child mortality by 2/3. Second, adolescent and reproductive health. 20% of total population in India adolescent, of which either sexually active or married. Problems to overcome are early motherhood, risk of mother and newborn, undernutrition and anemia, psychological immaturity, consequence of unprotected sex. Then reproductive tract infections and sexually transmitted infections. RTIs are mainly due to unsafe abortions, unclean delivery, poor menstrual hygiene, and unhygienic IUC, intrauterine contraceptive device insertion. All these are avoidable and proper preventive and curative measures under RCH program. Then gender issues. Gender inequality unfavorable to woman and girl child is an important hindrance of social development. This is evident in terms of food, education, medical care, access to financial resources, and decision making. Gender discrimination is to be removed. Others like skilled birth attendant and universal immunization to children. Maternal mortality. Death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of duration and site of pregnancy, from any cause related to or aggravated by pregnancy or its management, but not from accidental or incidental causes. That means, if a woman becomes pregnant by any cause which occurs during the pregnancy, like ectopic pregnancy or abortion, all those things comes under maternal mortality. But if we die in a car accident or something, anything with burns or a bomb blast, that will not come under maternal mortality because it is not because of pregnancy. Maternal mortality ratio, or in short we call it as MMR, is expressed in terms of maternal death per 1 lakh live birth. Maternal mortality rate. It indicates average of maternal death divided by number of women of reproductive age, that means between 15 to 49 years of age. In India, it is about to 120 compared to 0.5 of USA. 1 woman in 11 may die due to pregnancy-related complications in developing countries compared to 1 in 5,000 in developed countries. Maternal mortality rate is equal to maternal death in a year divided by number of live birth in a year into 1000. The direct causes of maternal mortality include sepsis, hemorrhage, PIH, eclampsia, uterine rupture, anesthesia death, and thromboembolism. Indirect causes include anemia, jaundice, medical disease like cardiac diseases, essential hypertension. Associated causes include surgical emergencies, traffic accident during pregnancy, myocardial infarction. We will see the direct causes one by one. First one is sepsis. Septic abortion, sepsis during puerperium, intrapartum infection can lead to septicemia. Puerperal sepsis is more common in home deliveries conducted by untrained person. Prolonged labor, prolonged preterm rupture of membrane, anemia can be predisposed to the infection. Hemorrhage during abortion or during ectopic pregnancy and postpartum hemorrhage are the important causes. Pregnancy-induced hypertension. Severe pregnancy-induced hypertension can cause cerebrovascular accident and renal failure. Eclampsia accounts for a large number of maternal deaths through the pulmonary edema, cardiac failure, cerebral hemorrhage, and hepatorenal failure. Anesthesia death. It occurred due to Mendelssohn syndrome and cardiac arrest. Spinal anesthesia can cause hypotension. Thromboembolism. It is rare in India, but in anemic, cardiac, and infected patient, a woman who is delivered by operative procedures are predisposed for this condition. Indirect causes include anemia, highly prevalent in India. It causes maternal death by cardiac failure, or it may contribute to maternal death in hemorrhagic shock due to abortion, ectopic pregnancy, antepartum hemorrhage, and postpartum hemorrhage. It also predisposed to sepsis, which is resistant to treatment unless anemia is corrected. Jaundice. Infective hepatitis is an indirect causes of maternal death due to coagulation failure and hepatic coma. Medical diseases. A woman with cardiac disease step down at least one grade during the pregnancy on account of increased cardiac output during pregnancy. Infection, embolism, pulmonary edema can cause death during pregnancy, labor, and during puerperium. How we can prevent it? Pregnancy care. Good health to women before pregnancy can reduce the risk of maternal death. Anemia can be corrected. Deworming, proper educational hygiene and nutrition can improve the health before pregnancy. Regular antenatal checkup throughout pregnancy is important in detecting medical disorders, preventing PIH, and instituting early treatment. Eclampsia can be prevented, malpresentations, contracted pelvis can be diagnosed, and uterine rupture avoided. Administration of injection tetanus toxoid can reduce tetanus death. Adequate antenatal bed at hospital provide proper care for all pregnant women with complication. Trained doctors and DIEs are required in conducting home deliveries for proper care, safe, clean deliveries. DIEs training or training of the untrained person. DIEs means the untrained person who conducts the delivery. They need to be trained, are being trained in asepsis and proper conduction of deliveries. This will reduce the maternal death caused by sepsis and tetanus. Detection of abnormal presentation, labor can avoid prolonged labor and uterine rupture. Then timely refer to higher centers will avoid complication of deliveries in the villages. High-risk pregnancy should refer to a hospital delivery. Trained staff at B.Sc is necessary to manage the home deliveries and supervise the pregnant woman. Transport and telecommunication facilities should be available to transfer the cases with unexpected complications during labor. MDP. Because of poor knowledge regarding the liberalized law, criminal abortions continue to occur in India. Routine injections of tetanus toxoid during pregnancy can eliminate tetanus. Providing free iron tablet have helped to reduce incidence of anemia in pregnancy. Anesthesia. Expert anesthetists should be available at all maternity centers. These are some of the preventive measures. And blood bank facilities should be available in all maternity centers. Grand multiparative associated with complications can be avoided by sterilization operation. Family plannings to space out pregnancies will help a woman to recover from the effect of childbirth. Childcare through clinics, immunization, and nutritional guidance has reduced the infant mortality rate in India recently. Emergency obstetric care. training of non-obstetrical surgeons in emergency obstetric such as cesarean section, forceps deliveries and manual removal of placenta, evacuation of abortion in rural and peripheral centers will reduce the number of referral to the first referral unit, save the time and save many lives. Then there is another term which is known as near miss mortality. It is an event in which a pregnant woman close to maternal death but does not die. That means she was facing the death, but due to the appropriate intervention, she's back to life. That is known as the near miss mortality. Traditionally, analysis of maternal death has been the criteria of choice for evaluating women's health and quality of obstetric care. Till some recent years back, we have been calculating only the maternal mortality rate, but nowadays, near miss, how many of them have been near to the death. Due to success of modern medicine, the deaths have become very rare in developed countries, which led to an interest in analyzing so-called near-miss events. Then maternal morbidity. Morbidity to a woman from any cause related to pregnancy or its management any time during the antepartum, intrapartum and postpartum period up to 42 days after delivery. Parameters for maternal morbidity includes fever more than 100.4 degree Fahrenheit, 38 degrees Celsius and continued more than 24 hours, blood pressure more than 140 by 90 mm of mercury, recurrent vaginal bleeding, HB less than 10.5 gram irrespective of gestational age, asymptomatic bacteriuria during pregnancy. Classification. These causes has been classified into direct into temporary and permanent, like temporary include APH, PPH, eclampsia, obstetrical labor, rupture of uterus, ectopic pregnancy, molar pregnancy. Permanent include vesicovaginal fistula, rectovaginal fistula, dyspareunia, prolapse, secondary infertility, obstetric palsy, Sheehan syndrome, etc. Indirect. These conditions are all the expressions of aggravated previous existing disease like malaria, hepatitis, TB and anemia. Perinatal mortality. Death among the fetus weighing 1000 gram or more at birth. That means by 28 weeks of gestation who die before or during delivery or within the first 7 days of delivery. That constitutes the perinatal mortality. Perinatal mortality rate closely reflects both standards of medical care and effectiveness of social and public health measures. International acceptance, the time limit of viability brought down to 500 gram. That means gestational age of 22 weeks or more. Worldwide, nearly 4 million newborns die within the first week of life and another 3 million are born dead. Perinatal mortality rate is 10 per 1000 in total birth in developed countries, while it is much higher in developing countries, that is 60 per 1000 in India. Predisposing factors like epidemiological, that means age over 30, parity above 5, low socioeconomic status, poor maternal nutritional status all adversely affect the pregnancy outcome. Medical disorders like anemia, PIH, GDM, syphilis, acute fever, infections are often associated. Perinatal death are increased due to hypoxia, IUGR, and prematurity and infection. Obstetric complications like antepartum hemorrhage, particularly abruptio of placenta, is responsible for 10% of perinatal death due to hypoxia. PIH, eclampsia is associated with high perinatal loss due to placental insufficiency. Cervical incompetence, premature effacement and dilatation of cervix between 24 to 36 weeks is responsible for significant perinatal loss. Complications of labor like dystocia from disproportion, CPD, malpresentation, abnormal uterine action, premature rupture of membrane may result in asphyxia and birth injuries contributed to the perinatal loss. Fetoplacental causes include multiple pregnancy, congenital malformation, IUGR and low birth weight babies, preterm premature rupture of membrane. The preventive measures include congenital fetal anomalies incompatible with life. This can be now identified in early pregnancy, and pregnancy can be terminated by before 20th week. Syphilis, Rh incompatibility, diabetes mellitus, and hypertensive disorders should diagnose during antenatal screening and adequately treated. Induction of labor or elective cesarean section after 37 weeks can prevent by sudden death near term. Postdated pregnancy should not allowed to occur. IUGR can be correctly diagnosed by USG. Fetal monitoring should be done for appropriate time for induction. Placenta previa, conservative management should be done to reduce parental mortality rate. Hospitalization of high-risk cases, stillbirth due to cord entanglement and knots cannot be avoided, but fetal monitoring should be able to detect this complication at the earliest. Then careful monitoring of the labor. Skilled birth attendant present during the labor. Provision of referral of neonatal service, especially to look after preterm babies. Health education of the mother regarding the newborn care. Educating the community to utilize family planning services available at BHCs. Autopsy of all perinatal death to detect what is the cause. Then perinatal mortality. It refers to stillbirth and neonatal death during the first 7 days of the life per 1,000 live birth in that year, or death among fetus weighing 1,000 grams or more at birth who die before or during delivery or within the first 7 days of life. Stillbirth plus early neonatal deaths induced 1,000 divided by total live birth in that particular year. It is closely reflects the standards, medically effective social and public health measures.